The two main groups of chemotherapy drugs used to treat breast cancer in the early stage setting are the anthracyclines and the taxanes. Hair loss is one of the most feared side effects of chemotherapy. It may affect the head, eyebrows, and eyelashes. Fortunately, it is usually reversible. With certain chemotherapy regimens, we can use scalp cooling systems, which may help some women keep some or quite a bit of their hair during chemotherapy. These systems have tightly fitting strap-on helmet-type caps filled with a gel coolant. They work by narrowing the blood vessels beneath the skin of the scalp, reducing the amount of chemotherapy medicine that reaches the hair follicles. With less chemotherapy medicine in the follicles, the hair may be less likely to fall out. The cold also decreases the activity of the hair follicles, which slows down cell division and makes the follicles less affected by chemotherapy. In the past, studies showed that age, tumor size, grade, lymph node involvement, and the subtype of breast cancer were the best available tools to predict which patients were at high risk. With the advent of computer models, we have been able to aggregate classical pathologic criteria and help physicians better assess risk. Today, in the genomic era, we have better tests such as the Oncotype DX assay and mammoprint to help us identify patients whose tumor biology make them likely to recur and who could benefit from treatments such as chemotherapy. Oncotype DX is a genomic assay which measures the expression level of specific cancer-related genes to reveal the underlying precise tumor biology of each patient. It predicts how likely breast cancer is to come back after surgery and the benefit of having chemotherapy. Oncotype DX was used originally in node-negative early-stage breast cancers and later for those with 1 to 3 axillary lymph node positive cancers. The report contains the recurrence score result, which is a number between 0 to 100. This score assesses the risk of recurrence and the likelihood that chemotherapy will benefit you. The recent RxPonder study for lymph node positive disease showed that indeed chemotherapy could be avoided in postmenopausal women for recurrence scores of 25 and below. Let's move on to the use of endocrine therapy in hormone receptor positive cancers. Hormonal therapy for breast cancer is the first targeted therapy used in any type of cancer. The selective estrogen receptor modulators, also known as SERMs, such as tamoxifen, are used in premenopausal women and act by inhibiting estrogen binding to the estrogen receptor. The aromatase inhibitors, on the other hand, are used in postmenopausal women and suppress estrogen synthesis through the aromatase pathway, thus lowering estrogen levels. Sometimes, the effectiveness of endocrine therapy is enhanced by adding on therapies such as gonadotropin-releasing hormone injections for ovarian function suppression. So how long do we give endocrine therapy for? Women treated with adjuvant endocrine therapy are usually treated for a minimum duration of 5 years. However, we are moving beyond 5 years with extended therapy offered to some with higher risk features. Recently, cyclin-dependent kinase inhibitors, also known as CDK4/6 inhibitors, have been changing practice in advanced hormone receptor positive breast cancer, with 3 agents, namely palbociclib, ribociclib, and abemaciclib, having FDA-approved indications in that setting now. CDK4/6 inhibitors are oral targeted drugs that are able to block cell cycle progression and prevent cancer cell growth. They are used in combination with standard anti-hormonal therapies. Addition of CDK4/6 inhibitors to standard endocrine therapy showed a benefit in terms of progression-free survival in both first-line as well as subsequent-line therapy in advanced breast cancer. One of the drugs, abemaciclib, has recently been reported to show promising activity in earlier stages of breast cancer, in particular those of a higher risk, such as those with many axillary lymph nodes involved cancer, or those having other high-risk features. Of note, this is an interim analysis, but adding abemaciclib to standard endocrine therapy showed an improved invasive disease-free survival rate. We await longer-term follow-up and data. There have been strategies to try and improve outcomes in HER2-positive cancers. In the Neosphere study, addition of pertuzumab to trastuzumab and docetaxel chemotherapy before surgery improved pathological complete response rates, meaning that there is no more cancer detected in the surgical sample. Those who achieved a pathological complete response had better progression-free survival outcomes compared to those who did not. Post-surgery, the Catherine trial of women with HER2-positive early breast cancers showed that those with residual invasive disease in their surgical sample after neoadjuvant chemotherapy and trastuzumab had better clinical outcomes with a drug known as TDM1. TDM1 is an antibody-drug conjugate. Antibody-drug conjugates are a new class of highly potent biological drugs designed by linking, in this case, a chemotherapy drug to an antibody. The antibody targets a specific antigen only found on the cancer cells. In triple-negative breast cancers, there have also been strategies to attempt to improve long-term outcomes. At the moment, promising results have been reported with immunotherapy given before surgery, such as pembrolizumab and atezolizumab given in combination with chemotherapy, which increase the pathological complete response rates, but long-term survival outcomes are not clear at the moment. In the post-surgical setting, the CREATE-X study showed an overall 5-year disease-free survival and overall survival significantly better with capecitabine for those with residual disease in the surgical specimen after neoadjuvant chemotherapy. This improvement in disease-free survival with capecitabine was driven in particular by improved outcomes among the triple-negative breast cancer cohort. Breast cancer survivorship essentially is a journey which starts at the time of diagnosis because most women with early-stage disease will be cured of their cancer and will not have recurrences. Even those with more advanced disease can survive for years as a result of improved therapeutic options. Patients invariably ask what they can do to improve their overall outcome from breast cancer. The follow-up period can provide an avenue for patients to report any concerning signs and symptoms. Side effects from treatment, including menopausal symptoms, reproductive, and bone health issues can be discussed too. Everyone copes with the diagnosis of breast cancer in different ways and are likely to experience a range of emotions. Dealing with the psychological impact of breast cancer is also an integral part of our management. Lifestyle modification can be an empowering and effective way to boost physical and mental health in breast cancer survivors and possibly to improve disease outcomes. This includes embarking on healthy eating habits, regular exercise, minimizing alcohol intake, and stress reduction to improve the overall quality of life. We are fortunate in this present time where research has resulted in a greater number of improved therapeutic choices than we had a decade ago. As such, the diagnosis of breast cancer is to be faced with courage and hope. In reality, many women are cured from their cancer and go on to lead happy and fulfilling lives. I hope this video has enabled you to gain an understanding on breast cancer and will help you in your journey through treatment and recovery.